So now we are discussing the chronic immunosuppressions. Chronic immunosuppression is usually required in the most of the patients. Whereas we have said those patients who is in only ocular symptoms and they do not progress, they may not require some steroids. But rest of the patients, most of the patients, they will require some glucocorticosteroids. Now let's talk about the steroids. Steroids. What are the indications? That any patient who is not having fully responsive to pyridostigmines, that will require the glucocorticosteroids. And now, how to start and which dose is to be started? Very important aspect is usually in all the conditions in medicines, we start glucocorticosteroids with a very high dose, that is 1 milligram per kilogram per day. That is usual starting dose. So in 60 kg, it will be around 60 milligram of prednisolone. But in case of a myasthenia, usually we start with 20 or 30 milligrams of steroids because initial steroids can cause a transient worsening because glucocorticosteroids can cause a muscle weakness in acute settings. So who is patient who is an OPD based patient? You should not start with a high dose of steroids but low dose of steroids. Patient gradually, if on response to 20 to 30 milligram of prednisolone, gradually increase the dose and reach to an optimal dose, that is around 60 milligram or 1 milligram per kilogram per day. Once the patient's dose has been reached, now patient is asymptomatic and have a good symptomatic relief also. We can dose taper after 3 or 4 months, but dose tapering should be very low, 5 to 10 milligram per month only. The usual side effects of corticosteroids, as we all know, that have a patient will have and problems with infections. Patients can have the osteoporosis. We should give calcium, vitamin D3, and immunizations, as we already been discussed. Now, glucocorticosteroid sparing drugs, because glucocorticosteroids only cannot be used for an lifelong periods. We should use the other drugs which will spare the glucocorticosteroids. Glucocorticosteroids is for a medium acting immunosuppressions, while these drugs are for a longer period of time, or possibly it's a lifelong treatment for the patients as the disease is lifelong. So which drugs to be used in patients with which medications? Those patients who are acetylcholine receptor positives or both negatives, usually drug of choice is azathioprine or mycophenolate mofetil. For those who are acetylcholine receptors negative and musk antibody positive, the response to azathioprine and mycophenolate are very less. So we use nowadays with rituximab. Otherwise, the therapy remains same as azathioprine and mycophenolate mofetil. Azathioprine, as we know, we usually start with 50 milligram. Increase the dose 2 to 3 milligram per kilogram per day. Usual side effect is bone marrow suppressions. So we have to monitor the WBC count, LFT. If WBC count is less than 4000, we have to look back and stop the drug temporarily. Mycophenolate mofetils has such a good drugs because that acts only in lymphocytes and do not have such a bone marrow suppressions. But very important thing is we should avoid the mycophenolate mofetils in a patient who is pregnant. Other drugs or a second line drugs like cyclosporins and tacrolimus can also be used. Rituximabs are in one of the CD20 antibody which is emerging drugs and used in many of the autoimmune conditions and nowadays used in a patient who is an anti-musk antibody positives. So we have discussed this drug therapy as a chronic immune therapy. Now we will discuss an acute therapy. So the acute therapy being that of a that is called as myasthenic crisis. Now how we will, what is a crisis? Crisis is any life-threatening conditions or a worsening of an myasthenia which is requiring an ventilations is called as a myasthenic crisis or an impending respiratory failure. Any patient who is having an increase in bulbar weakness should be considered that patients will develop respiratory distress, because one of the important things which is to be emphasized in these patients as normally in any patients we will have respiratory distress in the form of patient having increased respirations like that, but these patients do not have an increased respiratory muscle, because of a weakness, they don't have, seems to have a respiratory distress, and suddenly patient will go into respiratory failure. So clinical judgment is very important in these patients. Usual precipitating factors being drugs, as we have said that it is fluoroquinolones, macrolides, hematoglycosides. These are the common drugs which is offending and causing precipitations of myasthenia leading to myasthenic crisis. Any of the infections can cause and precipitates the patients with the myasthenic crisis. How will you diagnose the patient? Any patient who has an impending respiratory failure in a myasthenia should be considered to be having myasthenic crisis unless proved otherwise. Patient needs to be admitted in ICU. You need to have an elective intubations and ventilate to the patients. Specific therapy, rapidly acting immunosuppressions, that is IV immunoglobulins and plasma accents. IV immunoglobulins are 2 gram per kilogram in patients over a period of 2 to 5 grams is the dose. While plasma exchange 3 to 5 liters per exchange, like that 5 exchange in a week or 2 week periods will be required. Plasma exchange will essentially remove the antibody, while this will mechanism as such is unknown, but that binds to the antibody and leads to acute decrease in an antibody level. Both will this decreases the antibody level and patient will have rapid improvement. So all patient who is in crisis, we need to give IVIG and plasma exchange. Which are the other conditions where we have the IVIG and plasma exchange? Yes, that's in Guillain-Barré syndromes, and the second one being immune thrombocytopenia. Now we have understood so all almost things regarding myasthenia. We will go to the approach. So how we will approach to the patients with a myasthenia? Number one, you diagnose the patient appropriately, because this the treatment will be required for lifelong. Now search for associated conditions like thyrotoxicosis or other autoimmune conditions, because that also need to be treated. Patient is having an only ocular weakness only, then do the MRI, because other condition needs to be ruled out, because many conditions in a brain that can cause the third nerve lesions and that can cause the ptosis and weakness. So MRI needs to be ruled out. MRI needs to rule out other organic causes, and if the diagnosis is unequivocal that it's an ocular, the patient needs to be given the pyridostigmine. If response is satisfactory and patient is feeling good, okay, most of the patients won't have a generalized myasthenia, and wait the patients. If it is unsatisfactory, then you need to have an immunosuppression. Suppose the patient is having generalized myasthenia. Here you will have to give a pyridostigmine, then evaluate for thymectomy. If patient's functional capacity is good and you can do the thymectomy, do the thymectomy. And then immunosuppressions will be required. If the patient is in crisis, patient will need ICU care, ventilatory support, IVIG and plasmapheresis, and IVIG or plasmapheresis, and then patient will have comes into a generalized myasthenia. Then you needs to give the pyridostigmines and evaluate for thymectomy. If patient's functional capacity is good, do the thymectomy. If the functional capacity is not good, do the IVIG and then do the thymectomy. So this is overall management plan of myasthenia gravis. Hope you have understood, and we can have another topics some next day. Thanks.